The Foundation for Women and Girls with Blood Disorders is pleased to present Women and Bleeding Disorders. Welcome everyone, and good morning or good afternoon. And we actually had interest from our colleagues in Europe, so we'd like to say good evening to those of you who might be joining us from Europe. I'm Anne-Marie Nazaro, Executive Director of the Foundation, and after a word about us, I'll be happy to introduce our moderator. This foundation is the result of the insight and understanding drawn from the long and distinguished experience of 3 physicians. 2 are our faculty today, and the 3rd is Dr. Roshni Kulkarni, former director of CDC's Division of Blood Disorders. What they learned from their work is that there are serious medical consequences for women and girls who fail to get an accurate diagnosis, who are getting a delayed diagnosis of a blood disorder. From their learnings from their patients, they created this foundation, launched officially in July of 2010 with the designation as a 501c3 nonprofit, and they determined that its focus would be educating healthcare providers across disciplines. The intent was to cover providers for each life stage for women and girls. Using webinars and symposia at major medical meetings, the Foundation wants to achieve a world where all women and adolescent girls with blood disorders are correctly diagnosed, optimally treated, and managed at every life stage. The 3rd strategic tactic for our foundation is the website. And we're happy to say that today, with this webinar, this is the official launch of fwgbd.org. Please use it and use it frequently. And now I am honored to introduce our moderator, Dr. Evelyn Lockhart of Duke University, who is a member of the Medical Advisory Committee for our foundation and serves as the web chair. Evelyn?
Thank you, Anne-Marie. And hello, everyone, and welcome to today's webinar, Women and Bleeding Disorders. My name is Dr. Evelyn Lockhart, and I'm the Associate Medical Director of Transfusion Service at Duke University Medical Center. Today's presenters are Dr. Andra James, Associate Professor of Obstetrics and Gynecology and Associate Professor of Medicine, as well as Co-Director of the Women's Hemostasis and Thrombosis Clinic at Duke University Medical Center, and Dr. Barbara Konkle, Director of Translational Research at the Puget Sound Blood Center and Professor of Medicine in the Division of Hematology at the University of Washington in Seattle, Washington. Next slide. The planning committee for today's presentation includes Dr. James and Konkle, as well as Dr. Roshni Kulkarni from Michigan State University, Dr. Lynetta Jordan from Memorial Healthcare System in Florida, and Dr. Jennifer Dietrich from Baylor College of Medicine in Houston. Next slide, please. In accordance with the Duke University School of Medicine policy, the Faculty and Planning Committee for today's webinar have disclosed any significant financial interests or other relationships of interest relative to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of the information presented in this lecture. You may learn more about this at the Foundation's website, fwgbd.org. Next slide. To ensure the best sound quality during the webinar today, all attendees will be muted during the session. However, all attendees will have the opportunity to participate in a question and answer session with the instructors at the end of the webinar. During the webinar, you can submit your questions via the chat box in your GoToWebinar control panel on the right-hand side of your screen, and as illustrated here. We gladly welcome your input. Our first speaker today will be Dr. Andra James. Dr. James?
Hi, It's delightful to have this opportunity to speak to you today and speak to you specifically about women. And why? Why would we talk specifically about women? Well, women are different than men. Women are rarely affected by severe hemophilia. They are equally likely to have other bleeding disorders. And when they do, they are disproportionately affected due to the bleeding challenges of menstruation, miscarriage, childbirth. Additionally, we've learned a great deal about bleeding disorders in women in the last 20 years. This slide illustrates the prevalence of bleeding symptoms in von Willebrand disease. Von Willebrand disease is the most common inherited bleeding disorder. And so we have more data about it than we do about other bleeding disorders. You can see that menorrhagia is the most common symptom or sign that women with von Willebrand disease experience. You can see the prevalence of menorrhagia is 32 to 100% in series of women with von Willebrand disease. And in fact, the prevalence of menorrhagia in contemporary series with a more explicit diagnosis of either von Willebrand disease or menorrhagia, the prevalence of menorrhagia may be as high in those series as 80 to 90%. The prevalence of menorrhagia in other bleeding disorders is also high, with the prevalence in severe platelet dysfunction ranging from 50 to 98%, in Bernard-Soulier syndrome 51%, in Glanzmann's thrombocytopenia 98%, in factor XI deficiency 59%, in series of hemophilia carriage 10 to 57%, in rare factor deficiencies depending on the condition and the series anywhere from 35 to 70%. Then, as it turns out, the converse is true. In the last decade or two, starting with a series published by Mons Edlin, he explored the association between bleeding disorders and menorrhagia, looking at the prevalence of bleeding disorders among women with menorrhagia, and other investigators have followed suit. He found a high prevalence of von Willebrand disease and other bleeding disorders in women with menorrhagia. And in these various series, the range of von Willebrand disease has been from 5 to 20%, that of platelet dysfunction anywhere from less than 1% to 47%, depending on how platelet dysfunction was defined. The prevalence of factor XI deficiency anywhere from less than 1 to 4%, the prevalence of hemophilia carried from less than 1 to 4%, and rare factor deficiencies less than 1%. And these are in women who did not have a previously defined bleeding disorder. This slide illustrates the prevalence of bleeding disorders in adolescents with menorrhagia. And the prevalence of bleeding disorders in adolescents with menorrhagia is actually higher than the prevalence of bleeding disorders in adult women with menorrhagia. And again, this is the prevalence in adolescents with menorrhagia who have not previously been diagnosed with a bleeding disorder. The prevalence of von Willebrand disease was 5 to 36%, platelet dysfunction 2 to 44%, factor XI deficiency less than 1 to 4%, low factor VIII 8%, thrombocytopenia 13 to 20%. But it's not just menorrhagia. Other reproductive tract bleeding is more prevalent in women and girls with bleeding disorder. These data are from a survey that was conducted by the Centers for Disease Control. They studied women in hemophilia treatment centers
and compared them with matched controls. They found that not only was menorrhagia more common among women with von Willebrand disease compared to controls, but they also found that women with von Willebrand disease were more likely to have had a history of ovarian cysts. Now, this may not be immediately obvious why women with von Willebrand disease would be more likely to have a history of ovarian cysts, but it's probably because they were more likely to have had a hemorrhagic ovarian cyst. At the time of ovulation, there is very little bleeding in a normal, healthy woman. But in a woman with a bleeding disorder, the little bleeding that occurs at the time of ovulation can become significantly more if that bleeding does not stop, resulting in retroperitoneal bleeding, intraperitoneal bleeding, and bleeding back into the ovary. There's a number of bleeding disorders where hemorrhagic ovarian cysts have been reported. In a large series of women with von Willebrand disease, 6.8% were reported to have had a history of hemorrhagic ovarian cysts. It's also been reported in women with who are hemophilia carriers, women with afibrinogenemia, women with factor 10 deficiency, women with factor 13 deficiency, where the prevalence of a history of hemorrhagic ovarian cyst was 20%, and in women with platelet defects. This survey that was conducted by the Centers for Disease Control found other reproductive tract bleeding that was more prevalent in women with a history of von Willebrand disease compared to controls. They also found that there was a greater likelihood that women with von Willebrand disease were going to have had a history of endometriosis, 30% compared to 13%. Now, endometriosis is a condition whereby the lining of the uterus grows outside of the uterus itself. Now, it may not be obvious why that condition would be more likely to occur in women with a bleeding disorder than women without. But it turns out that the prevailing theory on why this condition occurs is that it occurs from retrograde menstruation, meaning menstruation that flows back out of the fallopian tubes. And retrograde menstruation is in fact more likely to occur with heavy menstrual bleeding or menorrhagia, and menorrhagia is more likely to occur in women with bleeding disorders, and that is well established. And it may be more common in women with bleeding disorders, or if women get this condition, it may be more symptomatic, or it may be that women with bleeding disorders are going to be symptomatic more often and are more likely to be diagnosed. It's not completely obvious. But in this survey conducted by the Centers for Disease Control, it was reported more often. And certainly those of us who take care of patients see this condition among our patients, and it's certainly a situation that needs to be investigated in the future. We have very few data about it, and there have been very few studies about it. The other conditions that were reported more often among women with von Willebrand disease were fibroids, endometrial hyperplasia, and polyps. Now, these are conditions, benign growths in the uterus, that would not be expected to occur more often in women with bleeding disorders. What they have in common, however, is that they present with bleeding. And women with bleeding disorders likely have bleeding earlier, more frequently, and more severely than women without bleeding disorders. So that is the likely explanation why women with von Willebrand disease reported these conditions more frequently than women without von Willebrand's disease. And not surprisingly then, These women with von Willebrand disease were more likely to have reported having had a hysterectomy than women without von Willebrand disease. And I'd like to point out that the cases and controls were matched by age and socioeconomic status. Moving on to pregnancy and childbirth. During pregnancy, women have increases in their clotting factors, decreases in their natural anticoagulants, and alterations in their fibrinolytic factors, overall changes that protect them from the hemostatic challenges of pregnancy and childbirth. But they are probably not sufficient to protect the woman with a bleeding disorder from an increased risk of bleeding. Nonetheless, it's not clear that women with a bleeding disorder are necessarily at an increased risk of miscarriage, with a couple of exceptions I'll discuss momentarily. These are reports of miscarriage in women with von Willebrand disease. If you look in the right column, it appears that perhaps they are at an increased risk, but I need to point out that the background rate of miscarriage is 15%, and in these series, the rate of miscarriage was reported to be anywhere from 0 to 30%. Now, what does appear to be different, however, is the rate of miscarriage among women with afibrinogenemia and factor 13 deficiency. In the series by Locke et al., you'll see that among the women with afibrinogenemia, 17% reported more than 2 miscarriages, and in the women with factor 13 deficiency, 63% reported more than 1 miscarriage. And this has been borne out by other studies. It appears that fibrinogen and factor 13 are both necessary to maintain normal platelet adherence or adhesion. After delivery, however, women with bleeding disorders appear to be vulnerable to postpartum hemorrhage. In the large series by Silver et al., there, however, didn't seem to be a statistically significant difference between postpartum hemorrhage reported among cases versus controls. But in a series published by Peter Koides in 2000, there was an increased rate reported among cases, self-report between cases versus controls. In the nationwide inpatient sample, a large national database, the rate of postpartum hemorrhage among women with von Willebrand disease compared to women without was increased about 50%. What does appear to be different, however, is the rate of postpartum hemorrhage after 24 hours postpartum, what we call delayed postpartum hemorrhage or secondary postpartum hemorrhage. In these series, where delayed or secondary postpartum hemorrhage was variably defined, the rate was anywhere from 2 to 25% in these women with bleeding disorders. This is compared to a background rate of less than 1%. We expect less than 1% of women who are discharged after childbirth to return with a delayed or what we call secondary postpartum hemorrhage. And it's not just the woman herself who we have to take into consideration during pregnancy and childbirth. There is the potential risk to an affected child. These are data from the Centers for Disease Control, UDC database from 569 male infants with hemophilia, and there was a difference in their risk of intracranial hemorrhage depending on whether they were delivered vaginally or by cesarean. The 385 who were delivered vaginally had a 4% rate of intracranial hemorrhage compared with the 184 who were delivered by cesarean who had a substantially reduced rate of intracranial hemorrhage, which was 0.5%. And that was not necessarily those who were delivered by cesarean before labor. So this has implications for how we manage the woman who's expecting a potentially affected infant. I'd like to turn the presentation over to my colleague, Dr. Barbara Konkle, who will talk about management of the pregnant patient with a bleeding disorder.
Thank you, Andy. It's my pleasure to speak with you today. In starting to talk about guidelines for management, I want to share with you that there have been a number of publications on guidelines for many of the areas that Andy discussed earlier in this presentation. This includes guidelines from Italy, the UK, Canada, the US, South Africa, and include guidelines for von Willebrand disease, hemophilia carriage, factor XI deficiency, rare bleeding disorders, next slide, as well as gynecologic issues and management at menarche, looking at menorrhagia as a risk factor, medical management of menorrhagia, ablation and hysterectomy, acute severe menorrhagia, hemorrhagic ovarian cysts, and endometriosis. Next slide. And then many on obstetric issues, including genetic counseling, preconception counseling, management of the potentially affected neonate, miscarriage, prophylaxis around delivery of the affected neonate, and postpartum hemorrhage. Next slide. In general, these are graded by level of evidence, with grade A from randomized controlled trials, grade B at different levels with different types of trials, and grade C with expert opinion. However, saying this, you'll notice as I present the rest of the talk that almost all of the recommendations are grade C, and therefore there is a lot of room for further studies in this area. Next slide. Beginning with menorrhagia, it's recognized that menstruation may be the first bleeding challenge that a young woman with a bleeding disorder experiences. And even if she's not had significant bleeding symptoms, her first menstrual bleeding may be acute and severe. And so for that reason, in girls who've been diagnosed with bleeding disorder, there should be a plan for that first menstrual period. As Andy noted, menorrhagia is the most common symptom that women with bleeding disorders experience, and it affects a significant portion of women with bleeding disorders. And on the converse, a significant portion of women with menorrhagia have undiagnosed bleeding disorders. Next slide. So in evaluating menstruation, it's helpful as providers to understand what is a normal menstrual period, and the American College of Obstetrics and Gynecology with the American Academy of Pediatrics have defined what is normal menstruation in girls and adolescents, and that is that the age of the first period, it begins at 11 to 14 years. The length of the cycle is 21 to 45 days. The length of the period should be 7 days or less, and they should use 3 to 6 pads or tampons per day. Next slide. Other variables that have predicted menorrhagia that we can use when we evaluate women who present with a complaint of menorrhagia are listed here. The greater than 80 milliliters per cycle is the blood loss definition of required to result in anemia, although that clearly be variable depending on iron stores. But these are soaking through one pad or more in an hour's time, soaking through night clothes, clots greater than 1 inch in diameter, or a low ferritin. Next slide. In terms of laboratory evaluation, there should be a complete blood count, a prothrombin time, and a PTT. A normal PTT will not rule out von Willebrand disease, and so there should be a specific evaluation for von Willebrand disease, including a measure of von Willebrand function, either erythrocyte cofactor or collagen binding, a measure of the von Willebrand protein, and factor VIII activity. Many times a study of platelet function using platelet aggregation studies are indicated, and other clotting factors should be measured depending on the screening PT and PTT, and then consideration for other non-hematologic tests, including perhaps thyroid function. It's known that von Willebrand factor synthesis is dependent on thyroid function, and thus hypothyroidism can be associated with acquired von Willebrand disease. Next slide. So this was the study I was going to refer to before the lab slide, and this was by Claire Phillips and colleagues, a study funded by the CDC, where they were looking at treatment of menorrhagia, but as part of that, a 12-page questionnaire was filled out by the subjects, and they were looking for symptoms that would be highly predictive for hemostatic abnormalities and determine sensitivity, specificity, and positive, negative predictive values. And then from that, they developed a short screening tool to identify females for testing and evaluation of a bleeding disorder. And the questions I will go through are ones that have high sensitivity for a bleeding disorder. And so those are: how many days did your period last, with a significant answer being greater than a week? 2, how often did you experience a sensation of gushing or flooding during your period? During your period, did you ever have bleeding where you could bleed through a tampon or napkin in less than or equal to 2 hours? Have you ever been treated for anemia? And you'll see there's overlap with the items that I mentioned previously. Has anyone in your family ever been diagnosed with a bleeding disorder? Next slide. Have you ever had a tooth extracted or had dental surgery? And then a positive answer is if the woman had problems with bleeding. Have you ever had surgery other than dental surgery? And again, with a positive answer being bleeding, problems with surgery. And have you ever been pregnant? And a positive answer having bleeding problems after delivery or after a miscarriage. Next slide. So in terms of recommendation for management of menorrhagia, first, in women with a bleeding disorder, management of menorrhagia requires the combined expertise of a gynecologist and a hematologist. Next slide. And the first-line therapy is combined hormonal contraception with or without tranexamic acid. And in the United States, there's, I think, a big advance in our ability to treat menorrhagia, and I'll mention this approach on the next slide, with that there is now a new oral formulation of tranexamic acid. Next slide. The value of combined hormonal contraception is not only that it reduces menstrual blood loss, but it also prevents ovulation. And shown here is a big hemorrhagic ovarian cyst. And so, as Andy noted, this can be a significant issue in women with bleeding disorders, and hormonal contraception will decrease the risk of these cysts. Next slide. Also, the levonorgestrel-coated IUD reduces menstrual blood loss. And shown in the insert is a graph from a study in women with underlying bleeding disorders and showing the hemoglobin concentration and an improvement in hemoglobin with the insertion of the IUD. Of note, this is a small study, but large studies in women without diagnosed bleeding disorders shows a significant decrease in menstrual blood flow with the use of the IUD, with the levonorgestrel IUD. Next slide. So women who fail or can't tolerate hormonal contraception, or in women who are trying to conceive, they may require other hemostatic treatment. In women with mild factor VIII deficiency or women with von Willebrand disease and some platelet disorders, they may be responsive to desmopressin. In a randomized study on women with bleeding disorders that I referred to previously, they found that antifibrinolytic therapy with tranexamic acid and desmopressin were both effective, but the tranexamic acid was resulted in a greater decrease in blood loss. So that is a good option for these women. In women with severe bleeding disorders or those who can't tolerate other approaches, they may need clotting factor concentrates. Next slide. Women who have completed childbearing may be candidates for endometrial ablation. From the data we have, it appears to be as effective in women with bleeding disorders as in women without bleeding disorders. Next slide. Women with bleeding disorders should not be deprived of the benefits of hysterectomy. Sometimes we know that in the past, a lot of women have had hysterectomies after they finish their childbearing, and I found that a good historical note in obtaining a bleeding history in family members. And so we think that hysterectomy has certainly been overused, but in some women it is the right approach. And in those women, we need to be sure that they have the correct prophylaxis to prevent bleeding during the procedure. And virally inactivated or recombinant clotting factor concentrates should be used as opposed to fresh frozen plasma or cryoprecipitate. Also in women who are GDAVP responsive, that also is an alternative for their treatment. Next slide. And hysterectomy should be performed in a center with appropriate laboratory, pharmacy, and blood bank support. Next slide. So preconception consultation and genetic counseling should be offered to all women who plan to pursue a pregnancy. And women should have the opportunity to meet with a knowledgeable genetic counselor about risk of transmission and options for prenatal diagnosis. So prenatal diagnosis would be applicable to women who have the potential to have a child with a severe bleeding disorder and would generally not be used in women who have milder bleeding disorders such as type 1 von Willebrand disease. Next slide. As Andy pointed out earlier, that women with bleeding disorders are not generally believed to increase risk of miscarriage unless they have either fibrinogen or factor 13 deficiency. Women who have fibrinogen deficiency and a bleeding phenotype should have replacement with fibrinogen during the pregnancy. And women with severe factor 13 deficiency also should receive replacement during pregnancy. And we now have virally inactivated products for fibrinogen and for factor 13 that can be utilized. Next slide. Management should also be done by a multidisciplinary team, which includes a hematologist, obstetrician, and with consultation in advance with the anesthesiologist. and women should give birth in a facility that has the laboratory, pharmacy, and blood bank support that woman requires. A plan for childbirth should be in place well before delivery, and I found that it's very helpful for the woman herself to have a copy of the plan, as well as the obstetrician, because then she can produce it in the delivery suite, which is very helpful for all. Factor levels should be reassessed once or twice in the third trimester of pregnancy in order to plan the delivery. In women who have mild factor VIII deficiency or type 1 von Willebrand disease, their values may normalize during pregnancy and can have a normal delivery, and we should advocate for that for those women. And women who require a factor concentrate, at the other extreme, we should be sure that what is needed is readily available. Next slide. Women with bleeding disorders are at risk of bleeding complications during pregnancy, particularly if they have low levels or have deficiencies that don't improve during pregnancy, and in the postpartum, where even those with levels that increase during pregnancy will decrease. In general, we think that women whose levels increase during pregnancy to within the normal range are safe for delivery, and we have some data to support that, although we have to recognize that they do not increase as much as women without a bleeding disorder. Hemophilia carriers can be at risk, and we need to be sure that the woman is attended to as well as the potential affected infant. Women who carry factor IX deficiency and have low levels are particularly at increased risk of bleeding because factor IX does not increase with pregnancy. The recommendation is that factor levels be above 50% at the time of delivery, and that if needed, virally inactivated or recombinant clotting factor concentrates should be used instead of FFP or cryoprecipitate. Next slide. Desmopressin acetate, as we discussed, can raise von Willebrand factor and factor VIII levels, and also appears to have clinical response in some platelet disorders. There's been a lot of use during pregnancy, and it appears to be safe. There is a little controversy about its use around the time of childbirth. There have been a number of reports of it used without apparent consequence, but we need to remember that it causes fluid retention. And outside of the use around delivery, we recommend significant fluid restriction. Shown here is the UK recommendation of 1,000 cc's for a 24-hour period, which is impossible at the time of delivery. And so if DDAVP is used around the time of delivery, it should be done with caution and with monitoring of serum sodium levels. Next slide. In terms of preventing postpartum hemorrhage, in women whose levels do not increase sufficiently and require clotting factor concentrates, the length of time that the concentrate should be continued depends on the type of delivery and whether there was a surgical procedure, either a cesarean section or a episiotomy or other surgical approach. I always remember the advice of Maggie Ragney, who's a hematologist at Pittsburgh and cares for a large Amish population with factor IX deficiency, and one of the women advised her as to how long she needed to continue the concentrate to be sure that she didn't bleed. And so I think sometimes there's a tendency to stop it too quickly, but to realize that these women may have undergone surgical procedures and need adequate replacement. Next slide. In terms of a potentially affected neonate, and these would apply to boys with hemophilia or with boys or girls who would have more severe bleeding disorders. That fetal scalp electrode and fetal scalp sampling are not of overall benefit and are risk and should be avoided. Next slide. And the delivery should be accomplished by the least traumatic method because of increased risk of intracranial hemorrhage. And so vacuum-assisted birth and forceps-assisted birth should not be used. Next slide. As I was taught by Dr. James, that you just can't stop at any point and switch to a cesarean section, that it can be too late. And so therefore, in advising on the delivery, that a plan for cesarean delivery should be considered sooner rather than later. Next slide. And in those where we're expecting a severely affected infant, umbilical cord blood should be obtained at the time of delivery. Neither factor VIII nor factor IX cross the placenta, so the umbilical cord blood gives a true factor VIII level. Factor IX is decreased, as are all the vitamin K dependent factors at the time of delivery, but one can use umbilical cord blood to rule out severe factor IX deficiency. For women who have mild bleeding disorders such as type 1 von Willebrand disease, there is not an indication for testing of the neonate, and there's nothing to suggest that those neonates can't have procedures such as circumcision without a delay. Next slide. And then in terms of prevention of postpartum hemorrhage, the third stage of labor should be actively managed to reduce blood loss and reduce the incidence of postpartum hemorrhage. Next slide. And antifibrinolytic therapy can be used to prevent or treat postpartum hemorrhage. Next slide. So in summary, women are rarely affected by severe hemophilia, but they are equally likely to have other bleeding disorders. And as Andy started with the note that they are disproportionately affected due to the bleeding challenges of menstruation, miscarriage, and childbirth. There is consensus regarding many of the issues pertaining to the management of women with bleeding disorders, which can be used to optimize their care. Thank you, and I'll now turn the session back over to the moderator.
Thank you very much, Dr. Konkle, and I'd like to thank both Dr. James and Dr. Konkle for their excellent presentations. For participants of this webinar interested in receiving continuing education credits, we direct you to visit the Foundation's website, fwgbd.org. Log on to myfwgbd, you can see here on the orange menu bar, and follow the links under My Past Webinars, directing you to the post-test. After completing the post-test, you will be asked to complete a webinar evaluation and will then be able to access your continuing education certificate online. Next slide. We'd like to inform everyone that the Foundation for Women and Girls with Blood Disorders' next webinar on pregnancy and thrombotic issues is scheduled for early 2012. Attendees of today's webinar will be emailed with the date of this webinar when it's announced. And of course, you can always visit our website to keep checking in for that date as well. Next slide. Additionally, the Foundation is a collaborating partner for the upcoming Thrombosis and Hemostasis Summit of North America, scheduled in Chicago on May 3rd through 5th, 2012. Please visit the Foundation's website for further details. Next slide. At this time, we'll proceed with the question and answer part of our program. As a reminder, participants can submit questions via the chat box in your GoToWebinar control panel on the right-hand side of your screen. Questions will be answered in the order they are received. Our first question today comes from Amy Williams, who asks, if a patient presents with endometriosis and ovarian cysts, should she be tested for a bleeding disorder? Dr. James, Dr. Konkle?
I think so. I think that when we have a patient who has reproductive tract bleeding of that magnitude, it probably justifies it. We have guidelines that have come from Claire Phillips' study on which patients with menorrhagia deserve testing. As Dr. Konkle presented, Dr. Phillips has given us some direction. Those patients with menorrhagia who also have flooding, who also have a family history, who also have anemia, who also have a personal history of other bleeding symptoms deserve a workup. We really don't have guidance for who to work up with other reproductive tract bleeding, but somebody who has both endometriosis and hemorrhagic ovarian cysts, perhaps, unless the ovarian cysts maybe are endometriosis, perhaps deserves a workup. Maybe we could refine that a little better. Do they also have menorrhagia? Do they have other personal history of bleeding? Do they have a family history? Do they have anemia? But certainly they need some sort of investigation beyond dismissal. I think that our consciousness has sure been raised with respect to the association between reproductive tract bleeding and bleeding disorders. When the CDC first surveyed OBGYNs 10 or 15 years ago now, only 4% of OBGYNs recognized an association between menorrhagia and women with bleeding disorders. And in their latest survey now, 2/3 of OBGYNs, or 3/4, recognize an association between menorrhagia and bleeding disorders. But in this particular case, there probably is an association. We don't have good data on what the sensitivity and specificity for that kind of reproductive tract bleeding and underlying bleeding disorder is, but it at least deserves further investigation and probably a workup. Dr. Konkle, Barb, what would you have to say?
I would just add I agree with that, and I would be guided in the evaluation by other bleeding symptoms or a family history of bleeding.
Excellent. Well, thank you both for that. Second question has come in from Patricia Rinders, who asks, I noticed that the MASAC recommendations were not mentioned. Although some of them are outdated, are they still relevant resources?
What we would have said today would have been congruent with anything that MASAC would have been recommending. Barb?
Yeah, I think probably the questioner is referring to the fact that they were not listed on the slide that reviewed who has published guidelines.
Yeah. So, yeah, when those were reviewed, they were issued by country guidelines, but yeah.
Well, we can, if the questioner would like to pass along any clarifications on that, we'll be happy to answer that. The third question we have is, what considerations for in vitro fertilization need to be accounted for in women with bleeding disorders, including the risk of multiple gestations?
So I'll start on that. With women in vitro fertilization, we would expect the outcome to be the same as women without a bleeding disorder, but the concern would be that she would have bleeding symptoms with the procedures. And it is true that those procedures may increase clotting factors, but we don't know specifically. So she would require, depending on her underlying bleeding disorder, she would require prophylaxis for the procedure, depending on that procedure. And unlike late in pregnancy, where von Willebrand factor is definitely increased and factor VIII is almost always increased, that wouldn't be true early in pregnancy, so she may require more treatment for early pregnancy procedures than later in pregnancy. If you want to add to that, Andy?
So I would just like to add that for hemophilia carriers undergoing in vitro fertilization, it gives us an excellent opportunity to talk to them preconceptionally about the option of pre-implantation diagnosis, where we can sample the embryo to see if the embryo is affected and only put back unaffected embryos. Couples can opt to undergo in vitro fertilization specifically for pre-implantation diagnosis if they are at risk for having a potentially affected infant. So it's how do I say it? It also gives, there's an opportunity there. Multiples increase the risk, multiples which are risk with in assisted reproductive technologies or in vitro fertilization are increase the risk of postpartum hemorrhage, and we have to be alert to that possibility and problem as well.
Excellent. Well, thank you for that and those other answers. At this time, we have no other questions in queue. We'll give you all an opportunity for any last questions at this point.
I just had one more comment about the MASAC guidelines. I think I had a further reflection on the question. When those guidelines were compiled, they were guidelines that had been published in journals, and MASAC guidelines are published online but haven't been published in journals. But it gives us an idea that perhaps the MASAC guidelines would be nice to have them published in peer-reviewed journals, too, for a wider distribution.
Well, at this time, this concludes our question and answer period. Next slide, please. You will be able to review this webinar for your reference or share today's proceedings with your colleagues by logging on to MyFWGBD and accessing this webinar under the My Past Webinars section. We thank you all for your attendance and participation today, and we look forward to your return for future Foundation webinars.